Good morning. Welcome to the October 10th meeting of the Care Delivery Transformation Committee. I apologize in advance. I am fighting my annual change of season cold because I can't figure out what season it is. But I will do my best to be the picture of health. We have a packed agenda today with some interesting work on Accountable Care Organization Certification Standards, the evaluation of our healthcare innovation investment work, some pre-filed, little snippet of pre-filed testimony for the cost trends hearings next week, and then some program updates. So we'll start with, ask for a motion to approve the minutes of June 13th, 2018. All in favor? Any corrections? We'll go forward. So the Accountable Care Organization Certification Standards, Katie?
Yeah. So I will tee this up and then hand it over to Catherine Harrison, who you know, and Courtney Anderson, Senior Policy Associate on our team, to take you through the presentation. But we are excited to have this first of a series of conversations around some updates that we're proposing making to our ACO certification program. As you know, there's a 2-year cycle for this program, and so we're coming up on the cycle of which we need to update the standards for 2019 certification. So we've been working closely in partnership with Mass Health. As you know, we have a close relationship with them on this program as they require all ACOs to be certified. And have had some preliminary conversations with ACOs about the standards proposed today. So we've gotten some early feedback already. The next step is to have a more formal final presentation for you all at the November CDT committee meeting, and then to move it to the board to vote to open it up for public comment just in the new year. So we've learned a lot through running the first iteration of this program. We're excited to share some of that with you and share the high-level proposal for the next set of standards.
Great, thanks, Katie. So, as Katie said, I think today's conversation is really about sort of setting the table and thinking about where we've been with the program and where we want to go for the next year. So when we first established these two certification standards, we have to always think about the bigger picture here and the vision for healthcare delivery that we're trying to accomplish. That vision, of course, is focused on patients being at the center, with providers and payers being held accountable for high-value care and integration across medical, behavioral, and health-related social needs. And ACO certification is one lever that we have to advance that vision. So really one of the core values for our program is that we create standards that help push the market in that direction. We want our program to encourage ACOs to partner with providers of social services and community-based organizations that, as we all know, at times provide services to patients that are just critical to their overall health and well-being. We also need to be a learning program and improving ourselves over time, just as we hope that the healthcare system is learning and improving itself. And we're, of course, always trying to seek to balance the interests of continuing to grow the public knowledge and expand transparency and understanding of ACOs with the real burden that we know falls on providers from doing this kind of reporting and certification activity. So we're mindful of all of these things as we think about our 2019 program. So to put the ACO certification program into a little bit of context, just looking at where we were in 2017 and, in many ways where we still are today. As you all know, there are multiple ACO models and programs in the market, including Medicare ACOs, commercial programs, and of course, the new Mass Health ACO program, which is having a major effect here in Massachusetts particularly. And the state of the evidence is really still developing, and that's clear across all of those programs. So in these initial few rounds of certification, both in 2017 and I think where we are now, our focus is really continuing to establish a set of standards that are applicable across these different models and across these different payer types. So this is important. Our program seeks to really have this multi-payer lens. And we look at core capabilities that an ACO needs to be successful under any of these models with any type of risk patient population. As I've alluded to already, we're also, continuing to build our knowledge and increase transparency as a main goal and purpose of this program, and to enable learning in the system. And of course, we're looking to make sure that our program aligns and complements other state efforts in this area, like programs that are going on in Mass Health and the Connectors' ongoing efforts to improve their carriers and their programs, and the Department of Public Health's various requirements. So all of this really means that for now, ACO certification standards really continue to be focused on operational and process aspects of ACOs. We're not yet at a point where we're able to certify ACOs based on actual quality or cost performance. Obviously, we have that as a vision for the future of the program as evidence continues to develop, but we're still kind of in that learning stage where we're focused more on the operational aspects. So this is the context we find ourselves in for 2017 and now, and Courtney's going to remind us of our 2017 standards and take us through a few additional slides.
So these are the specific standards that ACOs have to meet in 2017. First, ACOs had to attest to 4 prerequisites. They had to state that they obtained a risk-bearing provider organization certificate, that they had submitted any material change notices to the HBC, and that they comply with antitrust and patient protection laws. We also asked the ACOs to respond to 6 assessment criteria, which applicants had to demonstrate 4 competencies, or competencies in 4 domains. So they had to show us that they have patient-centered accountable governance, that they participate in quality-based risk contracts, that they maintain population health management programs, and they provide cross-continuum care. These responses were specifically evaluated by the HBC to see if the applicant had met our particular standard. The ACOs also had to respond to 9 supplemental information questions. These criteria address topics that the HBC believed to be relevant to the ACO model, but we didn't feel that there was enough evidence base to support setting a specific standard. So the applicants were expected to respond to all of the questions, but we didn't specifically evaluate them. By gathering this information, we're hoping to get enough information to develop future standards, and we're happy to report that the majority of the supplemental information questions we're proposing to be moved to assessment criteria in our future certification standards. So as Katie and Catherine both alluded to, we're aligned closely with Mass Health. Since the beginning, all Mass Health ACOs were required to obtain HBC certification by the start of the performance year in 2018. And the ACO certification programs work closely with Mass Health to align our application criteria with components of the Mass Health program, and we'll continue to do so for our 2019 criteria.
Just as a quick reminder, the bar was that you had to be participating at the time of certification of September of 2017 in a risk contract. So for Mass Health, some of the folks participating in the pilot ACO program, C3, who hadn't participated in another risk contract counted towards participating in a full risk contract. So it's just a technical point about, they weren't actually in the full program at that point in time, but they were in a pilot, and so we said that they were participating in a risk contract.
So you've seen this slide a number of times, but just a reminder, we certified 17 ACOs last year. Applicants are certified for a 2-year period, as Katie mentioned, and they'll be reapplying next year. 2 of the ACOs, though, I should mention, Health Collaborative Berkshires and Merrimack Valley Accountable Care Organization were certified as provisional because they were formed specifically for the Mass Health program, were not pilot ACOs. They didn't have as much experience as the other organizations, so we didn't hold them to all of the standards. So they were required to reapply for full certification in 2018, just submitted this October 1st, and we're currently reviewing their applications. So in keeping with one of our major program goals of transparency, we developed materials about the information received in the applications in order to report it back into the market. So we released 2 policy briefs, the first in April of this year, which provide provides a landscape of certified ACOs, and describe certain background information and key facts, such as the number of risk contacts that the ACOs hold. This September, we released our second policy brief, which is a deeper dive into the population health management activities of the ACOs. We specifically described the way the ACOs stratify their patient population for risk, how they assess their needs and preferences of their population, and how they address those needs that are identified through population health management programs that focus specifically on behavioral health and social determinants of health. And then also last month, we released a set of profiles which provide a snapshot of the ACOs, their individual one-pagers. And they describe information such as where the ACO provides care, the ACO's approximate patient count, and who the payers are with which the ACOs hold risk contracts. So after reviewing the applications and developing reports, the ACO certification team has gathered some lessons learned and key takeaways from the first round of certification that will help inform our 2019 standards. These lessons learned are both content-related and operational, which we'll discuss in a little bit. So in the first certification cycle, we learned a lot about ACO's governance structures. Specifically, some ACOs manage risk contracts in a single governing body, but others manage different contracts with different governing bodies. Our program certifies ACOs across these governance structures and risk contracts, so we're going to maintain that similar structure in future certification cycles. Our team also saw that ACOs manage performance improvement in a variety of ways that often involve operational staff and representatives from the governance structures. Our program, last year, our criteria specifically asked about the role of the governing body in performance improvement activities, but we'd like to expand in future criteria to understand all of the actors throughout the organization that participate in population or performance improvement. We found that risk stratification and needs assessment activities may not consistently inform the development of population health management programs. And we found that opportunities exist to strengthen the partnerships between ACOs and communities to address the social determinants of health. So our future criteria should allow for ACOs to demonstrate activities in all of these areas that are related to population health management. Regarding patient-centered care, we saw that almost all of the ACOs support patient-centered medical home transformation in some way, and opportunities exist to further development primary care capabilities related to integrating behavioral health in the primary care setting. And finally, ACOs continue to face challenges in sharing and exchanging clinical data. We see this as a critical aspect of improving care coordination and patient-centered care, providing patient-centered care. And we'd like to see ACOs demonstrate capabilities in this area.
Any questions about those findings? We haven't spent a lot of time talking publicly about the findings. Obviously, we've put together the briefs, but any questions on those takeaways?
So in order to inform our thinking for 2019 criteria development, we've been keeping apprised of state and national ACO models. In particular, as we said, we've been closely aligned with the Mass Health ACO program to coordinate capabilities. We've also been reviewing the requirements for the Medicare Shared Savings Program and the Next Gen ACO programs. Currently, CMS is working on evolving its MSSP programs to encourage providers to take on more downside risk. And for the Medicare Next Gen ACO program, they released new requirements in 2016 related specifically to certified EHRs. We also looked at the work of other organizations that have set ACO standards, such as NCQA, which has had an ACO certification program since 2012, but they haven't made any significant changes in that time. And then we also looked at the Accountable Care and Learning Collaborative's Accountable Care Atlas, which is they provide a roadmap for ACOs to help inform success in risk contracts.
Courtney, when we did this in 17, I think we were up front in terms of state action on ACO development. What have we seen in other states in terms of state?
Yeah, there's not a lot that we're aware of. There are other states that certainly have ACO programs or sort of, ACO-like structures. My understanding of most of those models, if not all, is that they differ from ours in the sense that it is the state as the payer that is developing those standards. I'm not aware of a multi-payer or, you know, an approach like ours where it's sort of certification on top of a contract and a, you know, a set of principles that are set specifically by the state as payer.
The only one of note is Vermont, and I just got an email this morning from somebody asking if we set a standard around percent of admin budget spent in an ACO, and I said, no, we do not do that. The Vermont model is sort of like our ACO certification and the RVPO process if it were merged, because they do have a multi-payer demonstration in Vermont, and they also, I will say, have 2 ACOs in Vermont. I think it's a slightly different process than the one that we're using here because 224 bifurcated the sort of looking at the risk and the financial aspects of ACO to the Division of Insurance and to the APC looking at the care delivery standards. But we're not exactly what Catherine said, not familiar with another program like ours.
So finally, as I mentioned earlier, we've identified some operational lessons learned, most of which focus on alleviating administrative burden for the providers in the program. Of course, we continue to seek the right balance of asking for clear documentation from the ACOs while also ensuring we don't overburden providers. One way we're seeking to do this is through leveraging other data sources such as the RPO program. Similarly, we'll work to align our documentation requirements with the intent of the standard that we're setting, and we'll move towards collecting data in structured formats to simplify the application process and our review process on our end. We'll also clarify the difference between background information versus assessment criteria, which Catherine will talk more about.
Great, thank you. So with all of that as backdrop, let me now try to give you a preview of what we actually are proposing our application might look like for 2019. So we're still envisioning 3 main sections of the application like we had last year. And this first section, in addition to capturing the prerequisites as we did in 2017, we're looking to get some basic identifying information about the ACO, again, similar to last year. We're also planning to ask the ACOs to give us some information in this section about their risk contracts and about the providers that participate in the ACO. These were elements that were included in last year's application. They were included as part of assessment criteria. And just from an organizational perspective, we think it makes more sense to capture this information up front as a way of our, sort of enhancing our understanding of who this organization is and how they operate kind of at the outset, particularly given our intention is not to evaluate ACO risk contracts or evaluate who is in the ACO in terms of participants. Those don't really fall into the assessment criteria bucket. So that's why we're thinking of pulling them out and putting them up front here. The other really important thing I'll note, which Courtney just alluded to, is this lesson we're taking to heart around leveraging other data sources, particularly the RPO program. So we're really thinking closely, and we'll continue to do so with the ACOs and our RPO colleagues about how we can streamline this and perhaps leverage information that ACOs are already submitting to RPO so that in certain cases they might not have to complete all of these elements or could, simply show us where to look on their RPO file to get some of this information. So moving to the assessment criteria section of the application, here's a side-by-side of our 2017 assessment criteria domains versus what we're thinking about for 2019. The first thing to note is that, last year we had 6 assessment criteria domains in these various structures. This year we're thinking about 5. We're cheating a little bit on that because our first one really is a capture of last year's first 2. So let me take us through each of these a little bit and explain what our standards are proposed to be in these areas. So first of all, patient-centered accountable governance. This is really, again, going to ask the ACOs to demonstrate that there is meaningful participation of ACO participants on the governing body, and also that there is patient representation within the governance structure including an actual role for a patient in governance, as well as having a patient and family advisory counselor, or PFAC. That one is pretty much unchanged, really, since last year. We think that that's an important standard. It aligns with Medicare standards. It aligns with Mass Health's expectations about patient representation. So we're more or less keeping that one the same. The next two, we're making some important changes to. So goal-oriented performance improvement strategy and comprehensive population health management strategy. These, again, are two topics that, as you can see, were represented in our certification standards last year. And what we're aiming to do this year in both cases is get more comprehensive information about ACO's approaches here. So, for example, for performance improvement strategy, whereas last year we asked very specifically, as Courtney said, about the role of the governing body in setting quality performance targets and in sort of driving that approach. This year, we're interested in gathering more information about the performance improvement strategy overall, reflecting on the fact that there is a role for the governing body, but that many ACOs told us that the real work and some of the effort in actually operationalizing this is done at other levels of the organization, and we'd like to be able to capture that and understand that more broadly. So that's our approach for that criterion. For population health management, similarly, last year we really thought about risk stratification, and we asked for an example of one population health management program that specifically addresses behavioral health and one that addresses social determinants of health. And I think we thought that this would be a good way for the ACO to describe an exemplar program or sort of how that would give us some insight into actually how they do population health management. But in the end, I think it's proven to be too narrow a lens through which to gather good data on ACO's approaches to population health management strategy overall. So we're thinking about broadening this one, and we'll weave in some of details that we received or some sort of aspects of this that we asked about in the supplemental information section last year. So we're going to weave in some of those questions that we had about how do they assess the needs and preferences that patients have, how do they work with community-based organizations to develop programs and policies that are relevant to the community population, and sort of put that all together in one sort of more comprehensive standard.
I have one just thing to add based on some early feedback we've gotten from ACOs. I think what we struggled with last time around setting these standards, in a vacuum, we didn't have any information concretely to work from, is sort of how organizational strategy happens versus how the ACO strategy. And for hospital-led ACOs, that may be different than how it would look for provider-led ACOs. So we've been exploring this a little bit with some providers to understand how does their organization approach strategy, and we mean that in the broadest sense: cost control, quality improvement, access, vulnerable populations, and other organizational goals such as risk adjustment, things like that might be important strategically to the organization. And how does that interplay work with the ACO strategy, which may be much more concretely grounded in the quality measures that are in their risk contracts and whatever TME benchmarks that they have in their contracts. So we're trying to understand that interplay, and I think last time around we felt very strongly, and I know commissioners felt very strongly about sort of the board of the ACO as that locus of strategy setting. And what we've come to understand from certification and conversations from providers is that that isn't always how it happens, and that may not be the best way for sort of driving that engagement. That being said, I don't think we're quite there yet in fleshing out a lot of the detail around these, so really interested in commissioners' feedback on that. We do want to get a bit stronger about requirements of working with community-based providers in both the development of population health programs and the implementation of them. We've heard that loud and clear from community-based providers that they want to be at the table for both the strategy setting and the development of the program, not just as a partner to execute the program. So our preliminary thinking is being a little bit stronger.
Can you give an example of that where somebody in the community said, we're missing this, we need to be involved?
Sure. So, let's take housing instability as an example. example. A lot of the Boston-based ACOs in particular, because of the affordable housing crisis in Boston, have rallied around that. And they, this is an issue, we want to solve this issue, we really want to partner with a Pine Street Inn or a housing provider, or even Boston Healthcare for the Homeless that is much more familiar with that population and community partners in that population. But they want to be there to develop what that approach is to addressing housing instability, as opposed to having the healthcare provider say, here's what we're going to do for our risk patients that are housing insecure, and here's what I need you to do for me, Pine Street Inn. Again, that's a theoretical example.
So to what extent are you going to require the boards and the ACOs to engage these community providers or other levels or layers of ACO?
I think we're thinking of it more operationally. So the operational staff of the ACO in their developing of population health management, there still is an element of looking at your risk population, looking at their needs and preferences as Catherine's have, looking at their social determinants of health screeners, as well as clinical indicators of risk, and then developing programs. So I think we're thinking less about requiring a board level involvement and more at the operational level, but would love feedback on that.
It's interesting, I remember the feedback from 2017 was we have to be on the governing board.
On the board, yeah.
And what I'm hearing from you is it's not necessarily the governing board that's making those decisions, it's more operational.
I think that's what we've heard from ACOs. We have engaged some community-based organizations and will continue to engage them throughout the next month. So we'd love to hear more directly from them about what they think is the ideal role. I just am personally not convinced that sort of having a seat on the board is that meaningful because of what we understand how the boards interact in these organizations.
Just wondering though, I could see each ACO approaching the implementation totally different, and so how do we, where are those opportunities and how do we measure them?
All important things that we will be grappling with in the coming days and months and weeks as we continue to flesh out these standards. So for the next one, patient-centered primary care, this would be new, and we did ask questions about this in our supplemental information section last year, but given the importance of primary care and strong primary care as a foundation of the ACO, this year we're feeling like it deserves some more prominence and some more attention as an evaluation standard or an assessment criterion. So we're going to try to set some standard here that sets some expectations about the need for ACOs to support primary care providers, both to deliver patient-centered care, including to grow and develop capabilities related to behavioral health integration. And finally, we'd like to craft a standard that speaks to the use of health information technology, particularly to support care coordination. Again, we feel like this is an important area. It is addressed in some of the other standards and programs that we've looked at. It's a tricky one to figure out what is really the right standard to set, but it's an important area that we think deserves some more focus, and we asked some questions about it again in supplemental information last year. So we have a sense of ACO's use of interoperable EHRs and other aspects of HIT, but we're going to work closely with our Mass Highway colleagues and others in the state to try to really develop a good standard here that can help move the market forward.
Can I just ask a question on that? Are you thinking a standard that requires some level of interoperability from every ACO participant, or is it a formatting standard where you have to make sure that all of your EHRs or your platforms are able to transmit information or receive information in a particular format? Are you thinking more of a requirement to engage, or is it around the format or the manner in which they implement?
I think our initial thinking is more the former. We're, of course, with the big X factor being how do you define interoperable. There are layers of what that means. And we're certainly mindful that, to have a standard that would require major changes in the hardware that ACOs are using would probably not be realistic. But our expectation would be that within the ACO providers, there is a good way of exchanging clinical information to support care coordination. Seems like that would be done through an interoperable EHR. And with external providers, some use of technology to facilitate care coordination in some way. We need help to really, narrow this one down though and define it in a way that is fair and sets the right standard for the whole market in where we are.
And as we've thought about these 5 standards versus the 6 standards that we had in the first version, for us, we were trying to move toward a more interconnected and foundational set of standards for ACOs. You have to have primary care. You have to have a way to convey information to each other. You have to have a board. You have to have an organizational strategy, and you have to have a population health management strategy. So if we think of these things, and we all agree that these things are foundational to being an ACO, then what we try to do is make them a bit more interconnected to really understand sort of a more full organizational picture, as Catherine said. Before, I think, and just for Dr. Kreider and those that weren't here the first time around, this was sort of after our public comment and how after we got a lot of feedback from the community about some standards that we put out that were potentially more challenging, and so we did away with those. And so it felt a little bit more siloed, like organizations were giving us pieces of information that were disconnected, and so we tried hard to come up with a set of standards that fit more like a puzzle, or look more like a puzzle to us so that we can understand who the organization is.
All right, so I'll quickly go through the next couple of slides. The next one here is a proposed new set of supplemental information standards. Let's see. Whoops. Okay. So in terms of what we had in 2017 versus 2019, as I mentioned, a lot of the 2017 SI questions we're going to be able to weave into our assessment criteria for 2019 in one way or other. So, for example, quality and financial analytics, patient experience of care, advanced HIT, these are assessing the needs and preferences of the patient population. These we all see as feeding what we're planning to do in assessment criteria for 2019. So that gives us some opportunity to fill in our SI section with some new topics. So for 2019, we're thinking about continuing to have a question around patient-centered advanced illness care, continuing to have a question about distribution of shared savings and performance-based provider compensation. Those are 2 elements from last year that we'd like to carry over. We think those topics are important. We think there's more to be gleaned in what ACOs are doing in this area before we move to set a standard. So those are 2 that we're proposing to maintain. But the balance of these, 3 through 9, really reflect mostly new topics. So we have oral health integration as one, resource stewardship, that's a little opaque, but that speaks to the efforts that ACOs are making or the policies they have in place to support community-based care where that's appropriate. And also weaving in really some of the elements of our consumer price transparency concept from last year in terms of how are they supporting patients to make high-value care choices. That's what we mean by resource stewardship. Early childhood development is another area we're interested in asking about. Addressing chronic pain, medication-assisted treatment strategy, crisis care. Those 3 I would put together a little bit in terms of behavioral health needs or related to behavioral health needs, and team-based care, including peers and community health workers, just emerging as an ever increasingly important topic for how we think about addressing social determinants, for how we think about kind of the holistic patient. So there's a lot we could talk through here. These are early ideas. Again, we're shopping all of this with stakeholders now and getting a lot of good feedback even in the initial few meetings that we've had. So finally, just to recap timeline, we'll be back with this committee at the end of November. And at that point, we hope to have had another round of meetings with ACOs, with consumer organizations, with state agencies, as many people as we can talk to who are interested in helping us inform our standards. But at that November meeting, we would have, real written out language for you to think through and help us with prior to taking that to the board in December and getting their approval, hopefully. Then we do a full public comment period. So again, lots of opportunity here for a variety of stakeholders to weigh in and advise us. We're looking to finalize the criteria and really the documentation requirements as well in the February timeframe. And then our next job will be setting up our technical infrastructure and getting our application system ready to take applications next summer.
This is a pretty forward-thinking list, so I compliment you on that. I think.
Thanks for not calling it a short word.
But I think really getting feedback from key constituents is really important, so I encourage people to weigh in as this process goes forward.
I'll go back to slide 18 for a second. Kathy. So the one observation as you get feedback from these ACOs is that it's, this is work for them. And this is work that's taken away from patient care. And I'm trying to lead in Lauren's question about the lack of data interoperability. So reporting is really hard on this. But we have to be mindful not to lose track of where most of the cost is. So chronic disease, diabetes, hypertension, obesity, there's advocacy for all of these elements, but there's no advocacy for hypertension, obesity, diabetes, and so on. So as you communicate with the ACOs to try to figure out how they can provide information to you, maybe we should be asking open-ended questions about how they are making improvements for the vast majority of illnesses, all of which are influenced by these elements that are not the primary diseases. It's really hard to do.
Thank you so much.
Thanks, Catherine. Moving to the Healthcare Innovation Investment Evaluation.
Good morning. It is still morning. So again, I'm Kathleen Connolly. I'm the director of our strategic investment team here at the HPC, and I'm really pleased to have Jessica Lang, our senior manager for evaluation, who's going to talk about our evaluation approach for our Healthcare Innovation Investment Awards today.
So, as you all know, there are 3 pathways within the Healthcare Innovation Investment Program. Each has a different distinct goal. The 6 neonatal abstinence syndrome awards are focused on improving the quality of care. The 4 telemedicine pilots have a goal of increasing access to behavioral health care for specific populations. And the 10 TCCI awards are focused on reducing cost growth while improving quality and access. So in evaluation, we need to keep those distinct goals in mind. The telemedicine pilots have now wrapped up their 1-year pilot period, and so next month we'll be back to share some preliminary findings from the evaluation of the telemedicine awards. But for today, we'd like to ground you in the approach that we're using for the evaluation of all 3 pathways. So, and first, a reminder that evaluation is a distinct function from the other ways that we engage with our awardees. On the strategic investment team, we do a lot of staff do engage with awardees around operational management, technical assistance, and learning and dissemination. When we do evaluation, it's different staff members, and it is a distinct function with a different time frame. It's meant to be analytical and reflective. When we're evaluating a care delivery initiative, we use a framework that was originally developed for large-scale CMMI programs, and it considers 3 domains. First, implementation. Was the initiative fully deployed as planned? Second, impact. Did the intended target population benefit? And finally, sustainability. Were there long-lasting changes in care delivery? And we use this framework also for the evaluation of CHART Phase 2. In that case, we hired an outside evaluation team to do a comprehensive evaluation of the whole cohort. For HCII, instead, the HPC staff are doing a comprehensive evaluation of all 20 initiatives, and we are bringing in an external contractor for a specific component. Turning to our methodology, we are using a mixed methods approach where we synthesize quantitative and qualitative data. On the quantitative side, we have a slate of key performance indicators for each award. This comes from, originally in their proposals, they all proposed a list of measures that they saw as important to track both the processes and outcomes for their program. We iterated with them to come up with a parsimonious set of measures for each award, which they have reported to us throughout the program period. We know that numbers still don't tell the whole story, and so we also collect a lot of qualitative data. A lot of it is in the form of written deliverables. Each award submits regular program updates where they answer questions about their program. And also our evaluation staff conducts interviews with staff at each program, and often with staff of partner organizations working with them. This synthesis is really important in reaching conclusions about changes in outcomes. When we observe a change in an outcome and we want to understand whether it can be attributed to the program, we look for a consistency in the change in the outcome and the narrative that we're getting qualitatively. Here's an example of how this works. This is from a neonatal abstinence syndrome program. Breastfeeding rates are an important performance metric for these programs. And so we measure the percentage of infants who get any breastfeeding, the percent who are breastfeeding at discharge. We also ask them about it in their program updates. And in this case, a lot of things can affect breastfeeding rates, of course, but when a provider is able to give specific examples, as this one did, of what they're doing and what they're observing that makes them think it's working, that strengthens our conclusion that they've successfully increased breastfeeding rates. So I'll pause there if there's any questions or comments about that approach. As I mentioned, our evaluation always bears in mind what is the goal of this specific program. This is a high-level logic model that represents the inpatient component of the NAS awards. Each awardee did provide a driver diagram in their original proposal, and we worked with them based on those driver diagrams to generate a logic model. So there is one for each program. This one represents all 6 sites doing the NAS care model. It shows on the left examples of the specific activities that they are doing. In the middle, the direct results for their target population, and on the right, the aim of their program. So by using a logic model, we can organize our data. We can generate a hypothesis that if these activities are successfully implemented, we should see an improvement in the direct results in the middle, leading ultimately to an improvement in the aim on the right. So in this case, the services for promoting breastfeeding, promoting skin-to-skin contact, optimization of the pharmacological treatment, and other kind of post-discharge transitional services should be reflected in the key performance indicators measuring the direct results in the middle. And we expect that to lead ultimately to a decrease in the amount of time that these babies spend in the hospital. So we use the logic model to tie together all the different data that we have into a coherent story for each award. Questions or thoughts? As I mentioned, we did bring in an external evaluation team for one part of this evaluation. We feel very strongly about including the patient voice in evaluation. And one area where we identified a gap in the literature was in patient perspectives on care planning. So we brought in a research team from Brandeis that has expertise in conducting IRB-approved research, including interviews with patients, including vulnerable groups such as people experiencing housing instability or end-of-life care. So they have been able to interview a number of patients already, and they'll be conducting focus groups with staff this fall. We have 4 TCCI awards participating, and they were chosen based on their interest in being part of this study, ability to provide enough patients, and the nature of their target populations. So this, the RTC2 study, as we call it, stands for Resonance and Relevance in Care Coordination. Includes Behavioral Health Network, which is serving families that have behavioral health needs as well as housing instability. Care Dimensions, which is serving patients who have needs in hospice and palliative care. Brookline Community Mental Health Center, and Boston Healthcare for the Homeless. So we are including a broad range of patients in order to hear their thoughts on whether all of the care planning processes that their awardees are implementing, is that meeting their needs? Are they feeling that this is getting them closer to their own goals? The ultimate goal of our evaluation is to answer the research questions that I mentioned at the beginning concerning implementation, impact, and sustainability. But those questions have a different meaning in the context of the different pathways goals, and so the output will look somewhat different for each pathway. The report for the NAS program will include the performance indicators that I mentioned, such as breastfeeding, parental contact, and their use of pharmacological treatment, as well as their aims, reducing the length of hospital stay. But also there will be a focus on institutional change and structure and cultural changes, such as staff training focused on reducing stigma around SED. For the telemedicine pilots that are focused on access, we needed to particularly consider patient satisfaction and the acceptability of the model to the providers and to the sites of care, which sometimes are a medical site like primary care, but can also be a school or a residence. For the TCCI awards, where there is a cost containment goal, we will be again focusing on acute care utilization as a proxy for cost, as well as looking at patient outcomes and their sustainability and business planning around the financial sustainability of their models.
So the evaluation has not happened in the latter two, is that correct?
It is in progress. We are still collecting data for TCCI and NAS. For telemedicine, we are finalizing the quantitative data. We've conducted interviews, and so we're in the analysis stage. For the others, interviews have been conducted for some, and there's still ongoing data collection.
And as Jessica mentioned, when we come back to the committee in November, we hope to be able to report on some preliminary findings for those telemedicine pilots as we're synthesizing that information.
Jessica, there are some cost implications for both the neonatal abstinence syndrome and the telemedicine pilots. I don't see those listed as sort of pieces that you're looking at.
So yeah, you're right. That's and again, it's because of the goals of the pathway, because TCCI was explicitly a cost containment, whereas neonatal abstinence syndrome, while certainly when people are discharged from the NICU faster, we expect that to be a cost-saving situation, but it is not a primary focus. So it is not explicitly a goal of evaluation to determine whether it reduces costs.
But from a program impact standpoint, we can certainly, draw some conclusions and present some information. I think you're also recalling when the folks from Lawrence were here, and they were very clear about some of the cost savings that had happened. So we'll be looking forward to sharing some of that information as well.
Yeah, so it's certainly not something that we ignore. Telemedicine pilots also, because these are short-term pilots, they really are much more about establishing the feasibility and effectiveness of this means of delivering behavioral health care. But there are some awardees who are tracking costs and who have some data to share on them.
Can you remind me, was the telemedicine pilot focused only on telehealth services for behavioral health?
Yes. So we do have a couple of the pilots are really using telemedicine as one tool in a large toolkit. So there's a lot of services that are part of the package. And as I said, some of them are doing it more in a medical setting and some in other kinds of settings. This is just a high-level timeline. And as I mentioned, we've been collecting data throughout the program period, and that's continuing for NAS and for TCCI. For telemedicine, we are in the analysis stage and hope to be able to share some preliminary findings soon. And the Brandeis component also at some point, when they're ready to share some findings, we'll ask them to come in and present themselves. And so we look forward to sharing findings over the next year or so.
Any questions?
So to switch gears a little bit, we hope everyone's getting excited for next week. We really are. We did a little bit of analysis, we did a lot of analysis, but are presenting a little bit of the analysis of pre-trial testimony for you all today in preparation for some topics that we're going to tee up for next week. So as you know, we solicited pre-trial testimony from stakeholders. We solicited it from 40 this year. Of note for this committee, lack of resources and access to behavioral health care is something on everyone's mind, but particularly as it relates to their ability to perform against the state's cost growth benchmark. That will be explored more in the second panel on the first day, which will be a panel of providers looking at timely access to behavioral health care and primary care. So I did a deep dive on the quality measurement alignment questions that we asked payers. Lauren, I wonder if you would be willing to do a quick update on the quality alignment task force. This relates to the task force's work that we shared with you last time around. Lauren's the chair of that task force. We do have a preliminary set of measures that we shared with you last time, and so that's the basis for this question for payers.
Sure. So as you see from the slide, this really speaks for itself, where the plans are on adopting the measure set that we as the task force had come to a near close to universal agreement on. Obviously, the commercial plans are fairly split on this, and there's been more alignment on the Medicaid side, likely due to the fact that if they're in an ACO contract, they have no option but to kind of adopt the measure set that has been approved by CMS. So I think there's, we, as chair of the task force, somewhat disappointed in the responses that we received on the plan, kind of given all of the engagement throughout the process. But I do think that, we still have an opportunity to work with the plan, engage with them through the task force to land on a set and think through the implementation. So just as a update on where we are, we have rolled up the process and work to date at the task force into a report that we plan on submitting to the legislature. We put the report out, posted it, solicited public comment on it, and I think we are in the process of synthesizing the feedback and comment on the process and recommendations of the task force date. But I think that going forward, it's our hope that even absent any statutory mandate to do this work, we can work with the plans and providers and other stakeholders on the task force to reach an agreement that and alignment on an aligned quality measure set.
Perhaps it's something we should ask the panel of payers next week.
I think that's a great idea. I think this topic, David can correct me if I'm wrong, but this topic is in line with the topics that we're considering for panel one. Is that fair? So alignment and improvement of alternative payment models. We also asked questions about their rates of alternative payment models on both HMO and PPO. Within those alternative payment models, how much is downside risk, which I know, Dr. Kreider, you have been particularly interested in. So we've done some analysis on that too that we'll be sharing with you next week. But I think it's a mixed bag. I think I think what was sort of most interesting to me is the does not apply response, because that means that they're not offering any risk contracts. So they felt that the quality measure set for ACOs did not apply to them. Those are largely the national carriers that responded does not apply. But you know, it's a mixed bag. Some commercial plans are willing to adopt the aligned measure set, which is a core measure set of 5 measures. Chronic disease outcome measures, a patient experience measure, and a behavioral health outcome measure, trending toward depression response and remission. The intention is that those core measures are in every risk contract where statistics is feasible. And then there's a menu of measures that we agreed upon that could be picked from for those risk contracts, but didn't necessarily need to be included in every one. The biggest, sort of most frequent rationale mentioned by plans was that they are still beholden to the HEDIS measures as part of their NCQA process, and so they're going to have to keep using those measures, even if the task force decided to not endorse them. So the second phase of the task force's work is developing some high priority areas of measures where the task force, which is providers, payers, consumer advocates, and state agencies, decided we really should have measures in these domains and risk contracts, but the measure science really isn't there yet. So as the task force moves into that second phase of work, we also asked payers what their priority areas for measurement are in ACO contracts. And we're pleased to see a good alignment with the task force's 2 priority areas, which are patient-reported outcome measures broadly. We've more specifically talked about them in an orthopedic context, and also in a behavioral health context. Depression remission is a patient-reported outcome measure, but behavioral health outcome measures more broadly were consistently mentioned as from payers as high priority areas for measurement in ACO context. So any questions about that or other questions that are top of mind getting ready for next week's hearings? Okay. So we'll shift gears again and pretty quickly go through some just program updates for you all, and then we can close out.
Sure. Okay. So I'm happy to report that we've engaged with all of our Shift Care awardees, and the contracting process is well underway. I think folks have seen in the past, we like to put out what's called an awardee profile, so a one-pager on each awardee. We've done that for CHART and doing that with our Healthcare Innovation Awards, and plan to do that for our Shift Care awardees as well. And the team and I are engaging with our awardees and thinking about learning opportunities that we'll want to conduct during the course of programs. As you all know, for our 2B, which is the initiation of pharmacologic treatment in the emergency department, we have a nice cohort of folks, so that'll be good learning experience across those entities. And we also are going to do a cohort-wide evaluation for that group of 9 awardees. This will give us a nice opportunity to look at different models and similar models in different settings, I should say, academic medical centers versus community hospitals, and really contribute more substantially to the evidence base. So we have a procurement underway for an external evaluation contractor to do that work, and we look forward to talking to you more about that.
So the legislature charged the HPC, as a reminder to you all, to issue a report around access to providers that treat patients with co-occurring disorder, which is both the presence of substance use disorder and mental illness. In that, we are charged with creating an inventory of providers, examining barriers to access, and issuing some recommendations to improve those barriers. So we'll be back soon with a lot more data, but since we received that charge, we have issued a survey in partnership with our colleagues at the Department of Mental Health and Department of Public Health to a pretty broad swath of providers who we believe, and I'll say individual providers and facility-based providers, who we believe are treating co-occurring disorder today. The survey methodology is largely derived from licensure data, but we also looked at insurance networks to cast a pretty broad net of who could possibly be providing these services. And we also asked questions about wait times and what types of vulnerable patients were they serving. and their ability to provide both substance use disorder and, importantly, evidence-based substance use disorder, medication-assisted treatment, as well as mental health services. And we've been discussing some policy recommendations again with our interagency partners. So we are hard at work at that, and we'll be back soon with a preview of those findings for you all.
So quickly to update you on our PCMH Prime certification program. Since we spoke with you in June, our numbers have increased just a bit. We've ticked up to 101 practices participating. Over the summer, we had 4 new practices join our pathway to PCMH Prime. South Boston Community Health Center, Greater Roslindale Medical and Dental Center, and 2 sites of the Community Health Center of Franklin County. So just continuing to hold steady, more or less around 100, but a few new entrants in the program.
Any progress on work with NCQA on the schedules?
Yes, thanks. We're working now to sign a contract with NCQA to implement that change that we discussed with the committee back in June of adopting the NCQA's new Distinction in Behavioral Health Integration Program as our new PCMH certification standards. So we're moving forward on that. We look to sign a contract with NCQA by the end of the year to be effective January 1st. And some important work will have to occur over the next month or so to really explain this change to our primary care participating practices. So we're in the process of thinking about those communications and developing a strategy right now. Expect we'll have a multi-pronged approach with emails and website announcements and obviously one-on-one support to help practices understand what that change might mean for them.
Kathy, can you spreadsheet those 79 practices for us? Just simple definition of size, onesies, twosies versus large groups, the number of docs, number of behavioral health people, and so on.
Sure, yes. I don't have that at my fingertips, but yeah, happy to provide some basics.
No more than 5 columns.
Okay. Got it. And just a word on our technical assistance program. We have a couple of practices that took us up on our offer last spring to do some individualized practice coaching, which we came to the decision to really skinny down our TA offering and try to focus where it looked like practices really needed support. So Greater New Bedford Health Center is one of the ones that we're engaged with right now. They're working with a practice coach to really focus in on implementing a new workflow to screen patients for anxiety and SUD. They're doing other kinds of VH screenings right now, but wanted to focus on those areas in particular. And the Family Health Center of Worcester came to us with a variety of different kinds of challenges, and we helped them kind of narrow down a project that would really focus on helping them overcome a number of barriers that they're having at their practice to really fully integrating BHI, including around communication and sort of engaging practice clinicians and staff in ways that we're going to work. So we're working with them now, and both of these TA projects will be concluding later this fall, and our engagement with our contractor Health Management Associates to do this coaching will also be up at the end of this year, calendar year.
So finally, I'm excited to share that this evening, as part of Mass Challenge Health Tech, they've recently rebranded. If you don't know that name, that's okay. We used to call them Pulse. They are under the umbrella of Mass Challenge, and so have rebranded themselves to be more aligned in name with Mass Challenge. But this is the digital health incubator that's part of Mass Challenge. And we are announcing tonight as part of their events with Hub Week our support for Mass Challenge Health Tech and these 5 challenge areas that are very much in line with policy priority areas of the Health Policy Commission. You'll see avoidable acute care use, both emergency department use and readmissions, as well as enabling access to integrated care that's integrated across medical, behavioral, and social. So these are very broad challenge areas. Startups, I think, have until the end of this week to apply to the cohort, and then they go through a pretty extensive vetting process to be selected to participate in the cohort. we will go through a matchmaking process with them, and if there's a match between these challenge areas and the needs of the startup, then we will be partnered and work together to refine their product and their company, which is a really exciting opportunity for us.
Do we get residuals?
Y'all know my boss. So that's it. Thanks so much.
Any questions about it? Yeah, thank you to the staff. Wonderful work as always. Our next meeting is scheduled for November 28th. And with that, I'll take a motion. So moved. Thank you all.
Thank you very much.